everyone. On behalf of Farnum Center and Chief Operating Officer Cheryl, I just want to welcome all of you. Thank you for coming and sitting down for this roundtable with Senator Shaheen. Obviously, over the course of the last few weeks and months, the Senator has been pivotal in helping to leverage some new resources, leverage bipartisan relationships, and really help to possibly free up some funds and some ways in which all of you can receive some assistance with some real flexibility, which I know has probably been an ongoing challenge, especially in this particular treatment community. So thank you all for being here, and I will gladly turn it over to the Senator to begin the roundtable.
Thank you very much, Scott, and thank you to Cheryl and the Farnum Center for hosting us. I'm going to ask, I have some, what I hope is positive news for all of us, but I'm going to ask everybody, I know you all know each other, but just so everybody knows who everyone is in the room, I'm going to ask everybody if you would begin by introducing everyone in the room, including the reporters who are here, the cameras, and I'll ask you to begin.
I'm Kathleen Murphy. I'm the Senior Vice President here at Farnum Center.
I'm Daisy Pierce, Executive Director at Navigating Recovery for Lakes Region.
I'm Sarah Gagnon. I'm the Vice President of Clinical Operations for Riverbend, which is the Conrad doorway.
Corey Gately, the Director of Substance Use Services at LRG Healthcare.
I'm Lori Meyer-Rose. I'm a clinician at the doorway at Cheshire Medical.
I'm John Burns. I'm the Director for SOS Recovery Community Organization.
Megan Shea, Families in Transition, New Horizons. I'm the Vice President of our Clinical and Support Services.
Maureen was very happy when she heard you were here.
Jake Fallon, the Director of the New England High Intensity Drug Trafficking Area. Good to see you.
Andrew Holmes, Chief Operating Officer for Easter Seals.
And Cheryl Wilkie, Chief Operating Officer of Farnum Center.
Yes, and we'll go around
I'm Madison Lightfoot. I'm with Senator Shaheen's staff.
Maureen Beauregard. I'm the President and CEO of Easter Seals, New Hampshire, Maine, Vermont, and Farnum. It's a very long, long title.
I'm Sarah Holmes. I'm Senator Shaheen's State Director.
And Kyle Heavey, Manchester Public Television.
I'm Carolyn Markey, Marketing and Communications for Farnum Center.
I am Eric Dancause. I'm Director of Business Development for the Farnum Center.
Hi everybody, I'm Meredith Mang. I'm a Business Development Officer here at Farnum Center.
I'm John Jarvis with Senator Shaheen's staff.
Scott Spradling, happy mascot and show kicker offer.
Well, thank you, Scott, and thank you all so much for coming out, being willing to sit down and talk with me, especially all of you who have traveled for a ways. I know that that's sometimes challenging, so thank you very much for doing that. As I said, I really wanted to have a conversation about what we now have in terms of the resources that are going to be available at the federal level for the next year. And I'm feeling much happier about this than I was, Daisy, when you came down to DC and testified, because there were three things. We sent a letter with support from the rest of the New Hampshire delegation to all of the appropriations staff back in the fall, and we said that there are three things that we really hope people consider. First, that we continue to have at least $1.5 billion in resources to help us deal with the opioid epidemic. Second, that we are able to have some flexibility in how we use those resources, because what we're hearing in New Hampshire is that it's not just opioids these days, it's also other drugs, stimulants that are challenging, methamphetamine and cocaine in particular. And third, that you continue the set aside, the 15% that the hardest hit states have been getting. And each of those three requests was included in the appropriations bill that we passed in December. So I think that's good news for us. Now, of course, the challenge is how we continue the great work that all of you are doing and how we use those resources. But that means that New Hampshire is going to get, again, close to that $35 million or so in state opioid response grants. So that's good news. And the flexibility piece, I think, is also very good news. You know, as I was traveling around, when I introduced the Turn the Tide Act, which many of you were there when we were talking about that, one of the things that we had heard in getting that ready was that flexibility was something that everybody needed, that as we were looking at the resources have been really helpful, but this epidemic is changing, and so we need to change in response to that and make sure we can continue to address what we're seeing out there. And so it was really the result of what we heard from all of you that us to try and push for that flexibility piece. And when I approached Roy Blunt and Patty Murray, who were the chair and ranking members on the appropriations subcommittee that deals with this issue, they said, well, yeah, let us go back and see what we're hearing in our states. And they came back and said, absolutely, we understand this is something that we're hearing as well, and we need to think about putting in some more language. So I really wanted to hear from all of you today, not just where we are as you're looking at the challenges we still face, but also on that particular flexibility piece, why that's important and what else, as we think about rolling out this new round of resources, what else we need to do to ensure that you can make most effective use of those dollars. So that's really why I'm here, and again, really appreciate everyone's coming in, what you're doing on a daily basis to address this continuing challenge in New Hampshire. And Cheryl, I'm going to ask you if you would start by telling me what you're seeing at the Farnum Center.
Sure. First, let me thank you, because Chris Scott called me and we had a long dialogue about how this was going to roll out, and I read the Turn the Tide, and it was really, you really are paying attention to New Hampshire, and I appreciate that, because we need somebody to be able to understand that the rates are already so low that it makes it very difficult to do what we all need to do when all of the money has to go for fee-for-services and there's no infrastructure money. So the nice piece of the flexibility of this is, we all receive $100 extra when it's an opioid user for a residential bed, and now it will be for cocaine and methamphetamines, which will allow us to receive a much higher rate for those typical drugs, which just expands the way our revenue will be able to come in, and that's a really important piece of what we're doing. In the big picture, even if we have to offset it through fee-for-services, it does offset more, because at $156 a day through BDAS, and I don't know what others, but I can tell you it costs at least $275 for residential for us to run the residential program. And at $156, because we have doctors and nurses, and they're, I'm sure you all have the same struggles where they're really ill and they need medications, and how do we come up with that when the fee-for-service is so low, but yet they have so many needs, and having this flexibility to be able to use these funds to add the extra 100, that 256 gets us a heck of a lot closer to the 275 break-even number, which saves so many lives. And I had a client speak recently, and what he was saying was that it is really important that we understand how many victims are not being created because he's sober today.
Wow.
And I think that's something we all should be thinking about, because we talk about crime and what it costs to go to prison and jail. But he was talking about he had victims on a regular basis. He was robbing houses, stores, and that it's been a victimless crime since he got sober and clean. He has not hurt another human being since that day. And a lot of times, people are very closed-minded, if it doesn't affect me, alcohol and drugs, then I don't, why should we help them? And I think speaking to, reducing the amount of victims because of the opioid crisis and the other drugs that are coming down our pike is a really nice way for everybody to understand we're doing this for everyone, not just that one person. So.
Yeah, that's a great quote. I wrote that down so I can understand.
It is. It's powerful,
Yeah, it really is.
So thank you. Thank you so much.
So what else are you all hearing? And what are you seeing?
So I can say from the Concord doorway in the past year, 57% of the people that have actually come in for an intake appointment do not have an opioid use disorder. A significant amount of them have alcohol dependence. And yes, methamphetamine is also a problem, but alcohol is still a huge problem in New Hampshire. And when the flex funds are limited for OUD, we can't provide them transportation for services, for hospitalization. We can't give them a phone to stay in contact with them. It has been a barrier, so I'm very happy to hear that there's going to be more flexibility.
Thank you. And we actually tried to get the committee to go to cover also alcohol misuse, and we're not able to get that done this year, but I think we can revisit it in the future, and we'll continue to show data that indicate percentage of what we're seeing, then hopefully we can persuade people.
I would even joke and say like, if just substances could be,
Yeah.
because there's always gonna be something new.
Yeah.
It's kind of like whack-a-mole, and so, meth is, but, and then we'll add alcohol, and then something else is gonna pop up, and so, as much as we can just use the term that kind of covers all our bases.
Yeah,
I had my
that's
first
what
cough
we've been
syrup
pushing.
one.
Oh, that- yeah, we're
That's
seeing that a lot.
a big one, Robitussin.
Wow.
So those with substance use disorder would be great.
How do you treat cough syrup?
Well, he went to the ED because over, a long period of time, it really tears up the stomach.
Yeah.
So, but it's, it has, it's the liver, so they treat it, they, from what I understand, they treat it the same way that they do with any type of sedative. Alcohol.
Yeah.
Exactly, so, but it's still there, there's still a lot of kind of gray area there too, because even though he hadn't suffered a seizure, they wanted to kind of just monitor him because of the possibility, so, but I haven't run into a lot of them, but from what I understand, I've been naive, so I guess that's out there.
With the expansion, it's gonna, and Cheryl was talking, it was really interesting because being able to have that extra funding with the additional substances will allow us to continue to look at expanding treatment around co-occurring disorders. Because what we're seeing, more and more people are coming in with mental health disorders. And so if we have licensed drug and alcohol counselors, we are missing that boat with them when they're with us for 6 months. So we're tapping into other mental health resources. But we could potentially, hire a duly licensed clinician to be able to treat the individual who's accessing our recovery housing in that moment. That would really help support their recovery. So it was interesting as you said that.
Yeah, I was just thinking, oh, go ahead, Maureen.
I'm also curious about the growth and use of spice. And during this coming year, I think it would be interesting to really be in contact with you about what is that about, how do you treat it, what is the incidence. In my former role at Families in Transition, there was a lot of folks at the shelter that use spice because it is so inexpensive. And it's one of the most scary things that, in all the time I've been here, it's one of the most scary things that I've seen because it just absolutely changes personality. It reminds me of like meth, but even maybe a little more edgy. So I think it would just be interesting to study that and to get that information to you. And I too agree that alcoholism is the granddaddy of them all, and that it really paves the way for all of this interdependency, multi-drug use, substance misuse. So.
And so do we break out, I should know this, but I don't, at the state level, spice as a separate?
It's like a mystery
Not
because
that
it
I'm
keeps
aware of.
changing.
It's the same thing with bath salts, I don't know
It's
that we.
under other.
It'd be under,
We
could see
cough
bath
syrup.
salts later too.
Bath salts.
Yeah.
Can you talk about how it keeps changing, Meg? Like understanding that, like.
In what sense?
How the substance itself keeps changing and it's so hard to track it.
Yeah, I mean, the data collection alone has been really difficult. And, without that kind of data, we're not really gonna continue to keep up with the trends. So we're working with multiple entities throughout the state to continue to look at how do we track what we're seeing. And everyone tracking in the same way, which is really difficult, as we all know.
To keep the data collection manageable, when I heard about this, I was really excited about the expansion of funds, but I also worry about the GIPRA, which is something that we need to collect for all of the people that are coming in through the doorway with opioid use disorder. It's a 32-page document of questions that the peers and case managers have to ask the client, and we need to do that multiple times.
And is that required at federal level or
SAMHSA?
Yeah.
So understand that the data is necessary and very useful, and from the client experience, it's like, get me what I need. Why are you asking me all these questions over and over again? And it can feel like pushing away.
if I could echo that, from the recovery, from peer recovery, most of the data you're collecting in KIPA type stuff is completely irrelevant to peer recovery. So it's more geared towards, it's geared towards abstinence, which isn't necessarily a successful outcome, and it's self-reported, so it's traditionally unreliable.
So give me some examples.
So I think for peer recovery, that's more about connection, and it's more about building recovery capital, or those external and internal resources. And so the data needs to reflect that. Like if we want to measure how we're doing, we need to measure connection, not whether you used, what substance you used, and when was the last time you used it. And some of those data points that chances are it's self-reported, so it's not reliable anyway. So let's, we know that in the peer recovery settings, that the evidence around it shows that if we maintain those connections and those peer supports, people are going to get well. So if we're able to show that level of connection, we know that that's heading in the right direction, and we know inevitably most people do recover, so they're heading in the right direction when we maintain those connections, because they're not isolating, and then we're likely to seek help when they need it. And then the other piece that, and I would echo as far as staying away from any one substance or two substances or three, like it needs to be, regardless of whether they're illicit or not illicit, whether it's alcohol or not, it just needs to be, as I say, I hate the term opioid crisis because it's an addiction crisis. But housing is just a huge, and a lot of the funding streams we see are built around, are not built around capital. They're built around operational. So how do we build that infrastructure and make it, a lot of them have barriers that, there's not enough housing first models that are permanent, that we know. We also know that people don't need to be abstinent to be housed and find wellness. And that, we've seen a lot of the successful outcomes of housing first models. We just need more of that, as well as the other side with the recovery housing. The chance of somebody maintaining their recovery when they're in a tent is pretty slim.
Yeah, no, that's, and there is a little more money for housing, but who that's going to come through, I don't know the answer to that. Do you, Sarah?
I would think HUD, but I'm not sure we can follow up.
Yeah, let us find out, because I know we got it. We did get some millions more to help with housing.
On the housing issue, and I know that everybody says this about every funding source, but the less restriction, the better. At Families in Transition, we're actually walking away from HUD funding because it is so restrictive. And when it comes to recovery housing, we have experience, I have experience doing that with MEG, and I think that it absolutely should be happening in big numbers. However, we need to be able to look at this resource in a different way than traditional financing. And we need to remember that the folks we're serving are mostly no or low income, and how do we build a operating budget that can support that? And having capital come in as a grant or 0% for 30 years, and then it's extended again. The flexibility in that funding is so critical, and that's the only way to make it work.
And that, as you know, is one of the real challenges, is getting that kind of flexibility.
New Hampshire housing bends over backwards to make it work.
New Hampshire housing is great.
As long as they can get the money, and they will not add that to it. So, yeah.
One of the other issues with housing too for us is that, with respect to sober housing, is a lot of the sober houses won't take people on an AT. So, we have people that have been induced, we have people that have been successful and stabilized on, whether it's Vivitrol or Suboxone, Subutex or whatever, but then you try to get them into the sober housing after maybe they've done a 28-day, maybe they've done a 90-day, but they can't because they're on an AT. And I can't, I take away their net.
Yeah, no, that's crazy. It goes to the housing first model, I think, and it's important to think about that as a way to help people.
And I understand they don't want to manage it, I understand that there's, I get it, the house managers don't want to deal with it, they don't want to, they don't want it in the house, they don't want it being misused or stolen, I get it, but, I can't.
We're not taking away their blood pressure meds, though.
That's, yeah. Well, we're gonna put them.
There's a stark difference there, you know, we've got to put them someplace. And we don't have a lot of respite beds, you know. Keene is a wasteland. We've tried really hard to, we've had a lot of people who've tried really hard to put up sober housing and to put up, transitional living, and it's, the whole NIMBY thing, but also so many zoning restrictions. I don't know how to get to the heart of trying to fast track and trying to, take a machete to cut through the red tape and try to, there's got to be some way that we can streamline some of these things. So
Has anybody got a model that you've seen that works well? Sober housing.
Yes. Yeah.
Families.
We've been doing, recovery housing for now almost 2 years, and the model that works really is what Maureen was talking about, having grading funding, so it's different revenue sources. But the harm reduction model is the way to go. Our recovery housing with women and children, we sent all of our family therapists to specialty training on child and parent psychotherapy. And so we decided not to treat just the individual and treat the whole family. And that, to me, is the best model. Because we're talking about generational impact. So there's plenty of models out there. It's just whether or not people want to take the risk, because it does come with risks. But it is about, if you allow people to stay on their meds, stay connected to treatment and housing, they're going to be successful.
And I can speak, I worked 2 years at Phoenix House and residential and 2 years at Antrim House, and I worked, MIT has been, you guys have been great. You have helped house lots. So
Yeah.
I appreciate what you've done.
Yeah, we've been able to successfully move people on with Section 8 vouchers, so we know that they're going to stay housed for a really long time, reunited with their kids and in recovery. That is the ultimate end goal.
Another thing I think that doesn't get often spoken about, but kind of fits as parallels to this housing first, is that's essentially harm reduction modeled housing, is harm reduction in general. So traditionally, federal funding just hasn't existed for that, and it really needs to. So, one of the things we really struggle with is trying to maintain a program where we're when we say we're going to meet people where they're at, it's not just like a tagline for us. We're really trying to do that, and that's not consistent when you look at recovery community organizations across even the state, let alone the country, and not looking at it from this abstinence-only approach, and going beyond MAT, but like when people are coming in under the influence, we don't want to just kick them out. And what we really need is a drop-in center. I often say, like, all right, like you can't be nodding off on the couch all day, but I really want to help you.
Yes.
And I wish we were a drop-in center, but I also have to be mindful of the people who are trying to protect their recovery and create a safe enough space for them. So like, you need to engage at some level, and I wish we had a drop-in center that you could go to as an alternative, rather than me saying like, you gotta leave out in the cold when it's 20 degrees out and you're not housed. So I think really looking at those harm reduction models to supplement the recovery side would bring a lot more people, because they're being, if we can create those drop-in centers and some of those harm reductions or service programs, and engage, a big part of a lot of those harm reduction, engage active drug users, and what better way to find out what's going on and what people need is than to talk to the people that need it. When we can treat them with dignity and respect and the resources they need, they're gonna get well. It's just a matter of, and at least we keep them alive in the process, whether that takes a year or 30 years, I don't really care. But keeping them alive is really critical, so.
So does anybody have a good drop-in center?
Well, we have the Hope for New Hampshire here in Manchester
Right.
that has that type of a model, and not many, but we do have that.
I know I've been to several that have since closed.
Yeah.
I was there.
Yeah.
And we have the Serenity Center in Keene, which has been
There you go.
right across the street
Yeah.
from the community kitchen, right down the street from
And
Peter's office. But
It's a great,
Very
it's good
convenient.
for everyone, and I'm curious about, as this money is, thank you again, you got it through, but how will it be, who will be writing how it will be spent and what the scope is, and is there any room this time for other things? And I don't mean like housing, because I know you need to stay with that, but instead of being like, oh, fee for service, this is it, here's $100, but with a little bit of creativity and some of the wonderful people at this table with all these great ideas, it seems to me like we could easily come together, and before it all just shows up in New Hampshire again and it kind of gets put out there, and say, all right, well, what do we really need to make sure that these centers and these treatment programs or recovery programs or TL housing, what do they need to be able to get the same amount of money, but be able to use it in a way that's going to be beneficial to everyone, versus trying to stay in a bucket that doesn't really lend to what your intention is, which is real health and growth for all of this.
Well, as you know, all those state opioid response grants come through the state. And so getting the state to look at how those dollars are being spent. And I don't know what, maybe somebody wants to talk a little bit about the doorway program and what you're seeing and how you feel that's working, and whether there are things that you think the state needs to be looking at in terms of the doorway program as we think about how those dollars are being spent.
Sure. Go for it. So I wanted to back up to the numbers, and I love that you brought your actual numbers. I didn't bring my actual numbers, but I do want to say that I would venture to say that all of us don't have accurate numbers for you about the folks that don't have opiate use disorder. I think the state has done a great job advertising the doorway program, but people on the street know that we will help them if they have opiate use disorder. So I don't think that we're seeing the actual, I don't think our data captures what's actually happening out there, because I think people aren't showing up. And people are showing up now. Before you got here, we were saying, wow, it's been a year. Like, wow. Whew. And so I think some of the things that are hard for us, I can speak from the central New Hampshire area and probably north too, because we work a little with the North Country, but just to bounce off what you were saying about a place for people to be. We've needed respite housing, and now we have some respite housing, but we're still missing this little piece where someone comes to us and says, I used today and I want help, and I have no place to be. I can't put them in respite housing. They used today. At risk for withdrawal, will likely be in withdrawal, or they already are in withdrawal, and we have no place to put, our local shelters won't take them. We have no place to put someone in those days. And so we've talked, wet shelter, something of that sort. We don't have those resources, and I would say that happens, you can probably speak to this too, I'd say that happens at least once a week in our area, that someone comes in that we have no place that we can put them.
And so what do you do with them if they go out the door?
Yes, we're trying to be very, very creative. There have been times where we've put someone in a hotel. That's a very risky venture as far as I'm concerned.
There are hotels that when I make a phone call, we have no openings.
Yeah. We are working really, really hard to make some inroads with our local shelters to say, if we've done all this work to evaluate and work with this person, maybe will you take them with a positive drug test? And so we're making some inroads there, but I'd say that's a big gap for us, is having no place to put someone in that situation. But I think overall, over a year, and join me here in this, we've made a lot of progress in how we place people. There's been, we very easily place people in a place like Farnum, and we're doing very good as far as, transportation is a little bit of a difficulty for us, Lakes Region North. Everybody always says, call Uber. We don't have that. Yeah. We just don't have that. And I think reaching out to we have one, yeah. I think reaching out to the outer areas of the doorway. I think in our doorway region, like right in the Lakes Region area, I would say we're doing some great work. But I would say that it's harder to reach those. It's a big area.
Yeah.
It's a big area.
I know Carroll County, for example, doesn't really have entry to the doorway.
Yeah.
You have to go either north or south, right?
Right, they have 4 doorways that touch their county, so, yeah, it's a little bit of a struggle in that area for sure. Maybe having some ways that we can do that a little more easily. How do we reach some of these areas that are further from us without creating another doorway? Because I know we don't want to do that, so.
And is there an assessment of the doorway program and how it's working that is going to be done?
There has been ongoing assessments. The numbers have been put out at least once now, and I assume that will continue to happen. there's been some discrepancies between the numbers and what, you know, because we have Safe Station here, which
Yeah.
is kind of Safe Station's numbers and the doorway numbers, but we're definitely reaching more people. It's kind of like the Safe Station program, right? I love the Safe Station program. Farnum's a receiving agency, but the reality is, you know, we set these programs up, like Safe Station, for doorways, without back doors, to go to treatment programs, to go to housing programs, and really what we're doing is, you know, what we did with Safe Station, and when the mayor approached us and asked us to take it, you know, you could see, like, if we hadn't taken it, it would have been another place where it was a stopgap, where they would be trying to find space. So being able to have them come right here is probably would be, for every doorway, a gift, right? Like, you have a treatment program with 30, 40 beds, and that's where they're gonna go. And I do believe if they do this money right, and they build the places that already exist, instead of trying to make more, because that's the thing, and then they spread it out, and then they don't have enough money to really hit their bills, they go out, you know? And so if we really take the time and sit down together and figure out, like, okay, you need this, and all right, that'll take care of your part of the doorway, and, you know, housing, all right, we can take care of that. Maybe we could really make sure this money was used in a way that just benefit all of the citizens of New Hampshire. And I know that's what your goal is, it's what my goal is, you know, and I want to continue to have these dialogues, and I'm working with, you know, the House and the Senate here to try to get in front of this a little bit more before this money comes in, because when it came last time, we didn't know what to do, we were kind of throwing it together quickly. It was, you know, all innocently done, but I don't think, I think we need to take more time this time. And so any information you can give us as you're going through this, of, you know, what the expectation is, when it's coming. I think if we can reconvene this group again, we can reconvene other groups to try to help make sure that it's getting spent well.
Yeah, and I was thinking maybe we can help convene that kind of a session.
You know, we presented, myself and Pete Fifield with Nick Tumpus presented to the commission today on behalf of the Seacoast IDN. And one of the comments Pete made that fits right with what Charles saying, what we're talking about here, is he's like, the doorway is like a great, there's nothing wrong with the system from a systematic approach. It's a great, like, that hub and spoke is effective, but a wheel doesn't work when it's only got a hub and no spokes. And right now, that's kind of where we're at. We got the hub, we got a few spokes, but like, there's not anywhere near the level of spokes that we need for it to be truly effective. So we got a lot of work to build out that spoke
I often
side.
say we've built the door for the doorway, but we need to build the house.
Yeah.
So we need,
Exactly.
so what we're talking about is funding for a whole system of care that has somebody come in at any given point and gets them through whatever treatment it is that they need. Riverbend and Concord is really fortunate that we were awarded funding for our crisis treatment center, which is a walk-in behavioral health and substance use center. So we have a nurse practitioner, we have security, we have a nurse, triage, clinicians. We're right next door to the doorway. So people can come in and get their needs met, and then there's that bridging to the long-term care, which, because it's within Concord, we have connections with the IDN, and we're able to see somebody through that entire system. But not everybody has that, and even if somebody comes into our doorway, we're not able to give them MAT right away. Corey's able to do that, so all the doorways are functioning a little bit differently, out of pure necessity. We're just grabbing the resources that we have in our area.
We're lucky in that we have a community partners, so we do meet once a month with all the people that are involved, and we kind of have a great head session to just talk about all the things that we can do. We are able to connect people. We actually have had a pretty productive year. You know, we work closely with Phoenix House in Keene. Dr. Mills is wonderful. So, I mean, I've experienced being able to get people into treatment, you know, certainly with the wonderful help of Farnum, thank God for medical detox. You know, and I have a good relationship with Eric and with Stephanie and Jessica, and so people come in and I can do their ASAM, I can get them assessed. I mean, I really have had people in treatment. You know, they come in at 9 o'clock, I've had them in treatment by 8 o'clock that night.
Wow.
And it doesn't happen often enough, I know that. But I mean, to be honest with you, the doorway, we've had the flexibility, and sometimes you have to think outside the box and be a little creative. We were lucky to, we have a shelter in town that typically closes in the summer, and we were able to work with them, and they gave us 4 beds. And we kept them open for they paid for someone to stay open, and we were able to give these people, there were at least, I can tell you, at least 3 people that got into treatment because we were able to keep them in a bed for a week before, a bed opened up someplace else. So, and sometimes it is just kind of just being creative, and, we don't want to see people going to the tents, and that's not a good plan. But, we've been able to use what we can get. The other 2 issues I wanted to bring up, and I don't, maybe this isn't the time or the place, but one of the issues that we run into is insurance. And one of my biggest issues is Medicare. I have an unbelievable amount of patients who are on disability. They come in, there is no coverage for mental health with Medicare. If they're lucky enough to be on APTD, and if their benefit amount is below the threshold, then their Medicaid can open without a deductible. But otherwise, it's really it's extremely difficult. I can't get them mental health services. I can't get them in to see MFS or MAPS in Keene. I can't get them a counselor. Maybe they can get their, I had a gentleman who was in my office yesterday morning. We see about 45% alcohol in our place. And he had a low-income subsidy. He didn't know what he had. He had no idea. But suddenly his Suboxone was $400 or $500 and some dollars because he had to meet a $400 deductible. He had no idea what that was. It took me 2 hours to get on it, which is fine. That's my job. But I mean, without somebody to call, sometimes that's all we do is get someone's insurance activated, get someone, on the phone with Social Security, because nobody explained to them that when they filed for Social Security, they were going to suddenly be on Medicare and they were going to lose their Medicaid. Then nobody told them that. And so I think that, whenever anyone comes into my office and they say, well, I'm going to appeal or I'm going to file for Social Security, I'm like, that's fine, but please ask them the question about your insurance so that you completely understand, you have choices now. So I just think, I don't know where that ball gets dropped, and I don't know how to pick it up, but I find probably a huge portion of my time is trying to explain to people what their insurance benefits are, trying to get them back on.
I wonder, as I listen to this, if it seems like there could be such a good relationship, like if there was a doorway here that just, we worked with like the money. I'm thinking as the money came in, it came in for a doorway and a treatment program to be together. So that you had the spokes, you could build the spokes, and the treatment program could deliver the services and in Keene or wherever you needed it to be. But it was more of a partnership versus you trying to call, 5 or 6 different places, but you knew that like Phoenix was yours or Farnum. Not that it had to ultimately be that, but that was who you were working with to make this and to build that up. I think that could be incredibly beneficial to everybody's agency because it helps build with the infrastructure, it helps build the relationships, and then I know we have great, if we have a bed, it's yours, right? That's not the thing. And we don't have that real struggle here, but I've heard it across the state where many people don't have the spokes, and I'm just wondering, because we've been able to work some of that out, we worked very closely with Meg, and if that was able to happen with maybe Phoenix and you, and then, you two got the money together, and then you figured out how you were gonna make the spokes and the wheel together, and it just takes away some of that stress, and everybody kind of, whoever's closest to you, and, work with that agency that already has what's existing. I just think it would be a beautiful way.
Utilizing everything that's there as opposed to reinventing.
Exactly.
Yeah.
Yes.
Right.
Thank you. You said it very well. There was I was just reading the doorway contract. I was asked to read it and help out with some things, and I realized there was just so much money put in that had it been, maybe given to you, and then, given to you with the idea, okay, here's your partner, and so they're going to get this much, you're going to get that much, and you all make it work together. Then your spokes are in place. And then you're like, okay, this is what I have to, for the doorway, my spokes were connected, we're gonna work together to figure this out. It just creates a much better atmosphere for all of us instead of this competition of how are we gonna figure it, like everybody gets, you know, pick a partner and just kind of like figure out how we're gonna do it. I think it would just be a really beautiful way to do it. I remember back in the day, you know, there wasn't a lot of us doing this, and it was really nice, you know, everybody had each other's back, and people were checking on people, and now it just feels like we're separated out a little bit more, but I don't believe that's intentional. I think it's because we're all busy, and that we could easily bring it back together, how it was written. And that's always what it comes down to, how we write it out and how it's gotta be dispensed, so. And it sounds like it would be the state who would be making those, so you'll bring in the cash and then the state figures it out, is that how am I running that right?
Yeah.
All right. I just wanna make sure. All right, got
I
that.
love that you're talking about that though, because I think that speaks to the fact that each of us in our own regions have very different needs, right? The needs that I have in the Laconia area are very different than the North Country, also very different than Nashua, yet we all sort of had the same idea. And I think that's all, what you're saying is obvious in an area like ours, like we have easy access to MAT treatment. Dr. Rasikot said to say hi. And so our program is vibrant and large, and it's easy for us to refer someone straight from the doorway to MAT treatment, same day, there's no questions. The doorway has provided us with the ability to help with rides and then find out what else anybody else needs.
Yeah.
So in the last 3 months, we've referred 89 people to MAT in our little area, and about 80% of those are still with us at the 30-day mark. But that shows some of that seamless transition. I happen to also run both programs, so it's.
Well, there you go.
But I think that speaks to that. When you have a
That's right.
doorway and a partner that can work that closely together, it's going to make for some seamless transitions. Like our patient navigators in both places are on the phone with each other all the time. This is what this person needs. Hey, they're coming to you. When they get to the door, meet them. You know, I think that speaks to that.
Yes.
That's what we need more of in our, you know, we need to be able to use the money to make those seamless. Plus, we have great connections. We have navigating as our subcontract for our recovery coaches. Lakes Region Mental Health is our clinician. Like, if I need to get someone into Lakes Region Mental Health, they've already worked with the person. So we have some of that by having those close relationships, but there are whole pieces of the doorway contract that have money that we're kind of going,
What do you do? What's on
yeah,
here?
we can't use it.
I know, I'm afraid a lot's gonna get sent back.
Give me an example.
Well, like, the flex funds are wonderful, but you can only spend $3 on a meal. It's hard for me to give somebody a meal for $3. That's, I think, came from SAMHSA. And so, we also have limitations on what we can spend on someone, so I hate to say that line for us was too big, but in our area, we're not spending that kind of money on people.
And transportation is another piece too.
Transportation is the big
That's what it is
piece.
with Medicare, is that
Yeah.
there's no CTS transportation
Yeah,
for
I know,
Medicare,
that's
so
a huge
right.
issue.
I've gotta get people from Swansea up to to Phoenix House IOP, 3 days, I can't Uber somebody 3 days a week for the next 12 weeks.
I'm thinking maybe we could open up a business for
Yes.
Lyft. What do you think? Like it'll be a lift for the northern, the income would be.
That's what I was gonna say, you could probably.
And that income we could use for infrastructure, so.
As we talk about resources and spokes, I wanted to put a plug in for the clinical side. My doorway friends have heard me talk about this too many times, but I can't stop myself.
Go, Sarah.
So we went to Vermont and did a road trip and kind of figured out how their hub and spoke system worked over there, and it's impressive. The biggest thing that's missing is the clinical intervention piece. Everyone has
The
the
biggest thing that's missing here.
in Vermont is this piece about a clinical intervention. So people can go in at many different levels, everywhere from a daily dosing clinic to, you know, come in whenever you need to. But the therapy is optional. So people, their death rates are way, way down, but everyone has just traded in taking a pill of Oxycontin for taking a Suboxone. The behavioral modification piece is not there. And we're focused on that in New Hampshire, and when we talk about improving the quality of MAT providers and the spokes, the clinical intervention, the peer intervention is so important to people's recovery so they can eventually get off of MAT.
Yeah, if that's what is best for them, and I agree with you that, you know, I hate to see New Hampshire become like Florida, or I go down there and they have signs everywhere, call 800 for Suboxone, like, that can't be our only go-to move. It's kind of the great move to quiet everybody, but I don't think it's a great move to think that's our only option. Because there are, and I'm totally about harm reduction. We all do it all day long. I'm always trying to reduce harm for myself, whether it's a headache or I'm hungry. You know, that's just the way it is. And when people are using drugs and alcohol, they really are just trying to reduce the harm to what's happening to themselves. And if we look at it that way, there's just no other way than to say that we need to be able to be open-minded to that's how it's going to be, whether it's MAT, whether it's Vivitrol, no matter what it is. But having those options is incredibly important. I agree with you.
I'm going to ask Jay if you would weigh in, because you will have some assessment of what you're seeing in terms of
Sure.
what's coming in to New Hampshire.
And thanks very much for the invite, Senator. Thanks very much for your support as well. You know, look how far we've come. Okay, I'm here representing law enforcement. Okay, public safety. And 5 years ago, and I feel very comfortable being here with you. I really do. And that certainly would not have been the case. Those of us that have been in this business for a while, that certainly would not have been the case 5, 7, maybe 4 years ago. Okay, so look how far we've come. You know, you know the folks that are on the ground. By the way, you do God's work. You really do, and I truly believe that because you are on the ground. Your boots on the ground here, and you know, it was said at the outset that you know, cocaine and methamphetamine are coming. Well, they're here, okay, and you know that. We do a threat assessment. The New England HIDA does a threat assessment for each state every year, and we find the same thing out. But you know who tells us that are you and people like you and law enforcement folks that are on the ground that tells us that. I can tell you from a big picture, but you can tell me as well. Fentanyl is going to put heroin out of business if it hasn't already. Okay, it's done. That ship sailed is right. I'm being a little conservative in that estimate, but that's true. And what's already here is meth, and what's coming down along, which is right on the heels of meth, is cocaine. So you know, you talk about, Senator, you talk about being flexible, and law enforcement, and certainly the New England HIDA has been flexible as well. We've changed our opioid response strategy to an overdose response strategy. And we've done nothing other than change the name because the problems remain the same. And you address the problem. You address the greatest threat, whether it's heroin or fentanyl or alcohol or tobacco or cocaine. But look, you know, law enforcement has found, okay, and I think you have as well, that we can't arrest ourselves out of this problem, but you know what? We can't treat ourselves out of this problem alone. It has to be, and you can't prevent your way out of it, and you can't educate your way out of it alone. And we're all in this together. It's treatment, it's recovery, it's enforcement, and it's education. It really is. And we're just starting to recognize that over the past 5 years. You've been on board for a while, Senator. You know, and we're going to have problems. We continue to have problems. You know, and you mentioned the problem with the MATs. Okay. Well, geez, 3 years ago, MATs were unknown. Medicinal. You mean you're going to give these people drugs when they're in drugs? Right. To get off drugs? This is crazy. Well, it's not crazy. It's not crazy. And research and science should dictate what gets done, and you'll be successful in trying to overcome that, because as I said earlier, education is key. Okay, education is part of this, and we're all in there with you. I can tell you that every cop in Manchester knows that it's better for someone to be here in Farnum than it is in Manchester lockup. Okay, I can tell you that every sheriff can tell you it's better to be here in Farnum, for somebody to be here in Farnum, than it is to be in Hillsborough County jail. And look where we've come over the past 5 or so years. Okay, we're not mutually, you know, the problem, I'm on a roll, so, you know, the problems, you know, you mentioned one with the MATs, and we know what the problems are, we really do. From a law enforcement perspective, we have a tendency to overclassify things. Oh, this information is law enforcement sensitive, so I can't tell you, because it's like, no, let's be real cheap.
Sounds like Washington.
It does, it does, and that's my, you know, that's where I'm coming from. And certainly on the public health sphere, HIPAA. We can't give that to you by it's HIPAA. That's just, we'll overcome that. Like you're gonna overcome the MAT issue, like we're gonna overcome the law enforcement sensitive issue. Because we're gonna keep on working at it, because this isn't going away. This isn't going away. We're not mutually exclusive, we have to be mutually inclusive. And we promote very heavily a public health, public safety partnership. Many thanks to, you know, and we all see Washington, or many of us from the state and the local area, see Washington as, you know, the Wizard of Oz. But in fairness, we're here for you.
Yeah, it's
we
us.
really are. It's us. It's
All of
us. It's us. Thanks for the opportunity, Sarah.
Yeah, no, thank you. And, you know, one of the things I hear when I talk to people in Washington, to my colleagues, about what works and what doesn't work, one of the things that I say, that I have seen in New Hampshire, is that where communities are successful is where everybody's working together.
Yes.
And it's law enforcement, it's schools, it's, you know, treatment, it's hospitals, it's everybody working together. That's where we've seen some real inroads. And on fentanyl, you know, we did do some things in this appropriations bill to try and address fentanyl in ways that we're not going to see immediately, but I hope long term, because we're sanctioning now companies in China who, if they're dealing with drug cartels or selling in places, and we can trace that, then they're going to be sanctioned. And so hopefully that will help some of that.
It's a long-term problem,
It is
so it'll take a long-term solution.
And I know Madison's giving me the high sign, but I have one other question, because one of the things that I know has been a huge challenge has been getting the people that we need to provide treatment, to do the counseling, to provide the recovery supports. Are you seeing any progress along those lines? Are we seeing more people who?
Can I simply just, as a recently licensed MLAC, can I just simply say that the licensure process is ridiculous. It's ridiculous. It's cumbersome. It's lengthy. It took. This is
the state licensure process.
Yeah, I had my MLAC. I mean, I was an LCMHC back in 2014 or something like that. But I had my MLAC application on the corner of my desk. I started it when I was at Phoenix House. I wrote the case study. It was 3 years. It was so overwhelming to me, and I know that. And I would call. I don't know if anyone knows Nick Pfeiffer, but I mean, I would call Nick and I'd say, "Am I doing this right?" He'd say, "You are being ridiculous. Just send it." But it's so lengthy and overwhelming. And then there was issues with I had a colleague that was moved from Florida. Yeah, it's like, come on. You know, do you want them or not? Should we not figure out a way to streamline the process somehow?
Yeah, there's new rules that came out that allow for reciprocity changes that came up recently that the governor signed off on, and I think you'll be able to see that isn't gonna be an issue across the board. And I do think that there are a lot of people out there that wanna work in this field. And I can tell you, we have 160 employees, and I think maybe 2 openings out of our 4 buildings. And I really, a lot of it is we're a friendly recovery workplace. I'm on the governor's task force for recovery friendly workplace. And we have so many people that work for us who've been here 6, 7 years that went through Farnum. And if you haven't dug into who is still around, and you have a little bit of faith and a little bit of trust and you give them a shot, some of my best people are people who have gone through Farnum or Phoenix or another program that apply here, that really, the why for them, right, because it matters. It matters so much they stick around. So I think the workforce is there. There's a lot of, that Brattleboro Retreat was just talking about closing. I don't know if you heard about that.
No, I hadn't
They need a $2 million bailout. So as much as Vermont has that hole, they're struggling. So I think there's a lot of different things happening, but again, I really believe it comes back to, we can all solve these problems together, but alone, we can solve our own, but it doesn't help everybody. When we did up at the State House, we had everybody up there, and Meg was there, and other people, we got the rates raised, the Medicaid, it took a little bit of noise, but that kind of thing, and getting parents together who want to help us work through this, sometimes we have to change the laws, and it's not fun, but it definitely has an impact if we get groups of people together to say, this is what we need to do, and so please keep us in mind as you're going forward, and because we will be doing more over the next year, and we're into another legislative session. We want to make sure that whatever's coming in, that we're getting in a way that is going to be beneficial to the whole state.
And Cheryl, just because you brought up the retreat, but one thing that we didn't bring up is adolescents. We're in big trouble. And I mean, I have sent a couple of children, thank God their parents had private insurance, otherwise I would have had no place to send them, but I was able to send them down to Connecticut. But I had people in my office today from Granite Pathways, and there's an IOP program that's opening up now, and it's a great program, but she's got room for 12 people, and she only has 6. She's like, why don't I have any people? Why aren't people signing up for this program? And I'm not sure how to get the word out, but when it comes to treating adolescents, this kid was on, I don't know how many benzos a day for the last 45 days, and he was in real serious risk of seizure. And, basically he said, well, we can give you, some medication and you can go home and detox with your mom, who happens to be a nurse. And she's like, he's not gonna stay home. I can't bar the windows and lock the doors. But that was the only option until we could get him to a place in Connecticut. But that's scaring me, I think, more than anything right now is what are we gonna do with our kids?
Well, I think we're going to be looking at that, right, with everything that happened, and making sure that we do have something for our young people.
But it has to be a program that's truly focused on adolescent development, psychology, all of that.
There's all those other those levels.
I think one area that New Hampshire struggles with is our educational funding system, aside from it being a mess. It's certainly not conducive for recovery high school type programs, like North Shore Recovery High School down in Massachusetts, and some of those programs. We desperately need that, as well as collegiate recovery programs, and they just don't exist in the state. So how can we find ways to fund those and build a funding model that can bring recovery high schools and collegiate recovery programs into New Hampshire effectively? Because the way the funding formula is right now, it'll never happen.
I do really encourage everybody to get real close to your senators and and really be spending time. Wouldn't you? I mean, because that's when you can. I mean, they called me and said, "Well, what bills do you want to write this year?" I'm like, "What bills?" Okay, well, I'm not political in that manner, but here's some of the things, and they're very willing, anything that we can help them understand, they can write bills that can really change what we're doing. It's really going that next step and kind of getting out of, we know these are the problems, who can help us fix it, and learning about that. And New Futures is good for that, because they can teach you a little bit about advocating, but it's not difficult if it's your neighbor who's your senator or
Or representative.
Yeah, representative. And those are the people who can help write the laws, and we show up and you call us all, and we all go and say, this would really help our community.
Well, we have made one promise today, and that is to convene discussion to continue the conversation around the doorway program and the funding that's coming in and how we can make sure it's used effectively. So
thank you so
Sarah,
much.
wrote that down.
Yep.
That is great.
So we will definitely do that.
Thank you. We will need that. We need that help to get us all together.
And you all know that you can contact our office if you have specific thoughts. Please do that. Chris Scott is actually on vacation, so he's not here today with us.
I told him all he checked in from sunny Florida.
Yeah.
He's
So
a great guy.
He is a great guy.
Feel free to
Yes, he is.
Well, thank you so
stay
much.
in touch.
Yeah, thank you.
Thank you all very
And good
much
luck
for-
to you in Washington. Our prayers are with you, and lots of love. There's a lot going on.
There is, so hopefully the foreign policy challenge will die down a little bit with Iran, and so that will make people feel less anxious about what's going on.
Just know we're here for you in New Hampshire.
Thank you.
Yeah.
Thank you all very much.
Thank you.
Oh, yes.